All right, here we go. Officially, CVPP. It is Tuesday. It's week 9. It's the fall. We're talking about EKG and ECG and things like that. So we left off. We were just starting to talk about the P wave. And normally, of course, if this is the isoelectric line, the P wave is that atrial, that wave of atrial depolarization spreading, over the atria. Then we have a PR segment, and then we have a QRS complex, right? And then that goes up to a T wave, and we repeat the whole thing. Why I draw that, I have much better examples right here. But the question now is, what could cause this? What's the matter with this one? Well, it's downward, right? We have a P wave that's facing down. So what's the deal with that? And this is limb lead 2. And has nothing to do with repolarization wave. Because if we could erase the QRS complex, we would see a repolarization wave here, but we can't. It's hidden by the QRS complex. Atrial repolarization wave is hidden there. What is that from? Well, let's do a hint. So normally the SA node, here's limb lead 1. Limb lead 2 would, or limb lead 2 would be down here, but there's the angle of orientation. So when the SA node fires, remember a lot of the current is going down Bachman's bundle and flowing this way. So therefore, the camera sees that current and draws an upright wave. It's almost coming right at it. So it's not biphasic. So now what could cause this? Just the opposite. Well, it would have to be a current going that way, right? So it's a current moving backwards from limb lead 1 or limb lead 2. Right? And so yeah, that's the deal. If the camera sees, or the angle of orientation sees a current moving directly away from it, it draws its wave upside down. And that's exactly what that's called. So this is an example of what's called retrograde conduction. Retrograde conduction. What are the causes of retrograde conduction? Well, ectopia, that is away from the SA node. Like, how about in the junctional region of the heart? How about the AV node beating the SA node to the punch? That could do the trick. So ectopia is a premature beat. That is a depolarization of tissue other than the SA node. Sometimes it's called a ectopic foci. Rebel cardiac cells, if you will. They're rebels because they're depolarizing ahead of time. But yeah, ectopic foci, cardiac cells which have depolarized way too fast. Where do retrograde running ectopia usually occur? So what could cause this? Bottom line, what could cause this inverted P wave? Well, if you get a PVC, or a premature atrial complex, or an ectopic foci that occurs in the left atria somewhere, that could do it, and it runs away from limb lead 1. As I said, an ectopic foci in the junctional region could certainly do it. That'll invert it. Occasionally, you could get in the ventricle, you could get a ectopia in the ventricles that runs backwards, or even in the you could. Oh, I missed that one. So occasionally, you can get in the bundle branches, you can get ectopia there, or in the bundle of His, or even in the ventricles themselves, something called a premature ventricular contraction, which we're not going to get to. But those can run backwards through the Purkinje system up the AV node, and and they can make a P wave go backwards. Right, so here's the most common example. So there's a run-of-the-mill PAC, premature atrial complex, that's occurred. An ectopic foci, some rebel cells have beaten the SA node. There's the king, right? Whatever reason, the king was a little slow, or maybe these guys were really fast and they sparked and are running the heart. But you see how the current is moving away from the camera. Same thing here. If we're in the junctional region, this one is in the bundle of His, but that can do the same type of deal. What else can you call these ectopic foci? Atrial premature complexes. We kind of said this already. Junctional premature complexes, ventricular premature complexes. They're just rebel cells that have beat the SA node to the punch. Right? And if you see these on EKG, you have an arrhythmia. That means your heart is not running normally, and that's called a heart arrhythmia. What do they do, these ectopic foci? Well, they create weird non-sinus heartbeats. Non-sinus, what does that mean, non-sinus? That means the SA node is not running the show. So that's non-sinus heartbeats, and they're called ectopic beats, premature beats, extra beats. Sometimes the beats can actually go so fast there can be one beat, and for one beat of the heart, the SA node loses and the SA node takes over after that. It can be all the time. Maybe the ectopic foci run the heart super fast all the time, and that is called a supraventricular tachycardia type situation where that happens and the SA node doesn't do anything. The concept of the burden of ectopic foci. So the burden of ectopic foci, it could be defined as the ratio between abnormal beats from the ectopic focus versus the normal beats. So the greater that number is, the more disabling the condition can become, especially if we're talking about premature ventricular contractions, because if you have a PVC, you are not ejecting blood out of the heart. So that ain't a good thing. All right, here's my completely politically incorrect cartoon. So here's the heart. This is the SA node running the heart, the jetliner. And here some ectopic foci, one in the atria, one in the junctional region, have taken over. We are taking over the sinus rhythm of the heart. And in some people this happens, and it can be very disabling in some people. In fact, when a person becomes aware that the heart is not beating right, then they are in the palpitation club. They are experiencing palpitations, whether the heart is running really fast or whether it's just an occasional beat or two. If they become aware of it, they have palpitations. Palpitations, what's the deal with them? They're usually benign, especially in young people like you, and they're extremely common. However, sometimes they can disrupt the rhythm of the heart so much that you start to get a decreased ejection fraction. And now you might have some dyspnea, maybe even a little dizziness because you're not getting enough oxygenated blood flowing out of a heart that's kind of beating erratically. That's usually, again, with PVCs, not so much with PACs or PJCs. But if you do become aware of your heart misbehaving, and a beat or two every now and then is no big deal, even a couple times a day. But if it's going and going for long periods of time, like in an hour you're feeling maybe 50 of these things or more. I'm just kind of making that number up. But if they really become prevalent, you need to get into a cardiologist right away so they can figure out what's going on. And it still could be perfectly normal and no big deal. Anxiety is a big problem with palpitations because people think they're going to die. And that turns on the sympathetics, and sympathetics have a tendency to make your heart even more twitchy and more prone to these ectopic foci. So I've been talking about this junctional region, this AV junctional region. So what in the heck actually is that? Let's see what it is. It's a very common place for ectopia to occur. And where is it? Well, Shu says in it's probably the most evidence-based cardiology, electrophysiology book I have. He says it extends from the AV node approach tracts through the AV node itself and through the bundle of His. So in other words, the junctional region really contains the AV node approach tracts, the AV node, and the bundle of His. Some authors include the tissue surrounding those regions, just the regular atrial tissue and ventricular tissue, but most don't. So if I ask what the junctional region is, and that's a nice setup for a question, right? That's what I'll call the junctional region. Here's a nice drawing of the junctional region. So there's this one has a double approach track. That's not the norm. I think 20% of people have this kind of anomalous approach track. There's the AV node, the main body of it, and there's the bundle of His and the penetrating fibers. So this is basically the junctional region. So if you have a junctional tachycardia, the wild, crazy ectopic foci is coming somewhere within this junctional region. Okay, and why is it so common for the junctional region to throw off these heart arrhythmias, or to create these heart arrhythmias? Because it does contain the second and the third string fastest depolarizing tissues in the body. Remember, the SA node, of course, is the fastest depolarizing tissue, but the AV node and bundle of His are right behind. Therefore, it's not too hard for, especially you go out drinking, you do things that make your heart extra irritable, it's easy for PJCs to occur. Now, PJCs can be heroes or zeros. Sometimes they can become mischievous and just flat out beat the SA node to the punch. But if the SA node ever fails for whatever reason, maybe you had a heart attack and your SA node isn't working very good anymore, or maybe you got an infection in it, for whatever the reason, the junctional region can take over the pacing duties of the heart and save the day. So it can run steadily for days or weeks or maybe even permanently. Mischievous, everything I kind of just said, it can be mischievous by beating the SA node to the punch. There's two types of mischievous behavior. If it just gets every now and then, beats the SA node to the punch, maybe a couple times a minute or maybe a couple times a day, still annoying, and you can usually, a lot of people can feel it. Some people don't feel these things, but it can be annoying. But the junctional region can also, one of those ectopic foci can beat incredibly fast, and even rhythmically beat incredibly fast, and spark what's called a junctional tachycardia, which is one of these supraventricular tachycardias. Anytime the heart goes over 100, and we like to see it go over 110, not like 105, or even better, 115. People can get anxious and their heart can run over around 100 beats, 110 beats a minute. If it starts getting 115, 120, and the patient's relaxed, that's a tachycardia of some kind. But still, by definition, anything over 100 is a tachycardia. The difference between foci, complexes, and beats, this is a good slide. So the misbehaving cardiac tissue cells that are the ectopic, the troublemakers, the rebels, they're called foci. They're called ectopic foci. Ectopic foci give rise to an EKG phenomenon that we're going to be looking at, and that phenomenon, the ectopic foci, give rise to premature junctional complexes, or PJCs. Right? The actual abnormally beating heart as a result of this ectopic foci, that's called premature junctional beats, or premature junctional contractions. PJCs is another one for that, so that gets confusing, right? Prejunctional complexes, the EKG phenomena. PJCs is also could be the actual physical beat, premature junctional contractions, or premature junctional beats here. So that always gets confusing, but this is a good slide to make a note card on, and that will help you study this material. Yeah, they are mischievous, usually found within the AV node or the approach tracks, but it could be further downstream. Could even be in the bundle of His, and those are still considered junctional ectopia. Sometimes it's the hero. So what if the SA node fails? Like I said, if you have a heart attack and your SA node is damaged and it doesn't make a spark anymore, well, then the junctional region, usually the AV node, will take over those duties. And once it takes over the duties, you're said to be in an escape rhythm, specifically a junctional escape rhythm. by definition, you have to see more than 3 consecutive beats coming from the junctional region to be an escape rhythm. If it's just occasional, every now and then you see 1 beat, 2 beats, and then it goes normal for 5-10 minutes, and then another 1 or 2 comes back. That's called just a junctional escape beat if you just see one of these things. I'll show you examples here in a minute. What could cause the SA node to fail? We already said myocardial infarction, in an infection of the SA node, digitalis toxicity, where people take too much of their digitalis medications. Grandpa and grandpa are getting old and they can't remember when they took it and if they have taken or haven't taken it, so it's easy to take too much, and that can make the heart really twitchy. And you could have SA node block, sinoatrial node block. Sometimes it's called sinus exit block or sinus arrest. And there's 2 different types of that, but the bottom line is the impulse doesn't get out of the SA node. Sometimes the SA node is so damaged from some of these things that it just doesn't form an action potential. But sometimes it forms an action potential. Maybe you have some tissue that has got, or the capsule around the SA node has gotten really thick, and the complex, the action potential can't get out. It's formed okay, but it can't get out of the capsule or through the capsule. Those both cause a sinoatrial node block. Right, so here's a 38-year-old in for a pre-employment physical. What do you make of this? Well, I grab some water here. Remember, the first job is to always check the heart rate. Remember that 300, 150, 100 rule? So if and you use the peak of the R wave here is the measuring stick. So if the next one was here, that would be 300. If the next QRS complex, the peak was here, that'd be 150, 100, 75, 60, 50. Just a hair slower than 50, just kind of using that method. So we have a bradycardia going, but not a severe bradycardia. Also note the RR interval between these 2 peaks of the R wave should always be the same. It's a little harder to eyeball when the heart's going really slow, but we'll see some. It's really important in picking out PACs, premature atrial contractions. When you see this dot right here, that means this exact same pattern goes on and on and on and on. So this is just a bradycardia. Now let's look at our waveforms. So where's the P wave? That's the first problem. Remember, it's supposed to have a P wave, QRS complex, and then a T wave. Where's the P wave? Well, there it is. There's no PR segment, and the P wave is upside down. So what's the deal with that? That's an inverted P wave. That means the current is running away from limb lead 2. So this is a junctional. This is a junctional escape rhythm, actually, because it goes on and on and on. It's more than 3. So we have a junctional escape rhythm. We can actually tell where the ectopic focus is. We know it's either in the approach tract or it's in the proximal part of the AV node. And I'll show you how we can tell that in a second. All right, don't forget this. Everybody can remember 300, 150, 100. I always forget this number. So I always remember one of the meanest, awesomest football players back in the day in the 60s with a guy for the Rams, the LA Rams back then, named Deacon Jones. He was a menace. Huge guy for back in those days. There's Johnny Unitas. So his number was 75, so that's one of my numbers I always memorize. So Deacon Jones comes, and then I can just remember 60, 50, and 43, and 37. I don't know how I remember those, but I can remember them. Anyway, these are not as important. It's not very accurate, but up in here, this is pretty accurate, this 350, 100 rule. All right, so that's everything I just told you. So there's actually the P wave upside down. And remember, the P wave, usually you have a P wave and then a PR segment, that, right? That makes up the PR complex. So we don't have any PR segment here at all. And when you don't have a PR segment and the wave is inverted, you just assume it's coming from the junctional region, right? All right, so this is a non-sinus heartbeat. The SA node's definitely not involved here. And it's a junctional escape rhythm because there's more than 3 of those in a row. So everything I just said, the P wave will always be inverted in a junctional or in junctional ectopia. Even if it's junctional tachycardia, it'll be inverted because the current is running away, retrograde from lead 1. PR segment will always be absent. And decremental conduction is not working then, right? If you get an action potential sparked in the SA node, there's nothing going to be slowed down, so the ventricles and atria can contract at the same time. So you will lose a little bit of ejection fraction if this is going on a lot. The P wave also is not always visible. It can be hidden behind the QRS complex, or it might actually be toward the T wave, kind of to the right of the complex, of the QRS complex. So here's an example of exactly what we're looking at a cartoon. So if it's occurring in the junctional region, you have most of the flow of electricity is going this way. So limb lead 2 is going to see it moving away, and it's going to draw the waveform down like that. And there's going to be no delay because the action potential is happening inside the AV node, and that decremental slowdown region of the AV node doesn't work. Let's see, so EKG appearance. So this is very important. There's a big, remember that's worth like 20 stars when you see one that big. The AV approach track, or the proximal AV node, if the junctional ectopia occurs in this region, the wave will be inverted and right before the QRS complex. If you don't see one, that means it's in the distal AV node it's occurred. If you see one coming out the backside, kind of before the T wave, an inverted wave, that's a bundle of His ectopia. So here's the classic chart. So anything in green, here's the approach tracks. Usually there's 1, but this case they drew 2 in. And this is the proximal half. Why is it proximal? Because the current is flowing this direction. So proximal distal. So if the ectopic foci occurs anywhere in here, you're going to get an inverted P wave. If it occurs in the distal part of the AV node, you're going to get a P wave that's hidden. You're not going to see it. It's going to be hidden by the QRS complex. And if you get one that is actually in the AV node or in the bundle of His or the approach tracks, you're going to get the P wave after the QRS complex and usually before the T wave. 18-year-old female comes in with some weird movements in her chest. You get out your trusty 12 lead EKG, and what do you think? It's a sinus rhythm? Well, what's the law? The law is to always get the heart rate first. And these are all looking like you can see the big box here and here. So these are running about halfway between. So that's 300, 150. So this is running about 100 beats per minute. So it's a tachycardia, but it's not a great tachycardia. Look at the RR interval next. Actually, let me get my mark drawing back out here. All right, RR intervals are right here. They look pretty standard across the board. Now let's look at the waveforms. And again, where's the P wave? You can see the QRS complex, the T wave. P wave is right here. So it's another one of those inverted P waves. We can see it. So that means it's got to be coming from the proximal part of the AV node or the approach tracks. Okay. Yeah, so I mean technically, because the rate is about 100, a little over 100, if you do the 1500 box rule, little box rule, technically this is a junctional tachycardia. It's definitely not a sinus rhythm because there's not a single normal P wave anywhere, but it's going too fast, so this is a junctional tachycardia. Okay, there's a blow up of the P wave. Right, everything I said already, definitely not a sinus rhythm. You can pause that and look at that if you need to. Junctional tachycardia. Again, if it's over 100, I prefer it to be 115 at least. But technically, if it's over 100, and it's coming from the junctional region, you got yourself a junctional tachycardia, which is not always a good thing to have, by the way. We'll look at that next time more specifically. It is a member of the supraventricular tachycardia. It's not a super common tachycardia, though. Let's look at this PR segment a little bit more. I've kind of been talking about it, but let's make it official. There's a nice view. The P wave, PR segment. Together, the P wave and the PR segment are called the PR interval. Guyton calls it the PQ interval because technically it begins, the PR interval starts at the beginning of the P wave and it ends at the down limb, the downward deflection of the Q wave. The trouble is, a lot of times you don't have a Q wave. Your lead has to be positioned just right to see a Q wave. So a lot of times all you see is a waveform going up. You see the R wave heading up. So therefore, it's confusing. It's better to call it the PR wave since the Q wave is not really there. So that's the story with that. It should be 3 by 5 millimeters. I guess we haven't gotten that far yet. The P wave, the PR interval includes the P wave and PR segment. You guys know this already. I just told you why that is. It's the PR interval because the Q wave is usually not there. What is it, kind of electrophysiologically speaking, what is it? It's defined as the time it takes the action potential to travel through both of the right and left atriomyocardia, through the AV node, into the bundle of His and even the Purkinje fibers. That is the kind of the time. This you have to, I mean, there's a zillion stars here. You have to memorize this. So 3 by 5 rule, the PR interval should be, it should fit between 3 and 5 millimeters. And we know 1 millimeter is one little box, so it should fit between 3 and 5 little boxes is what's normal. If you can convert millimeters or little boxes into centimeters, remember the 0.04 is one little box, the duration across this axis here. Right, there's a little box, it's this part right here. So 3 times 0.04 is 0.12, and 5 times 0.05 is 20 seconds. So you could also say the PR interval should be between 0.12 and 0.20 seconds. You should always use limb lead number 2 to look at it. The duration is, yeah, everything I said. Yep, one big box, so 5 millimeters or 3 millimeters. Okay, another important thing, because sometimes you can have a 3 millimeter PR interval and the PR segment is basically not even there. So another rule to have a normal PR interval, you have to have a PR segment, a visible PR segment. If there's not a good PR segment, I don't care how big it is, it's not normal. There has to be a PR segment present. Okay, does this patient have a PR interval? Well, there's the P wave, a normal P wave, Kira's complex T wave. But there's the PR segment. Yeah, this is normal. There's the P wave, PR segment. So that's fine. Right? Everybody's good. And we can measure it. It's got to be between 3 by 5 little boxes. So 1, 2, 3. It's just at 3. A lot of times you'll see them just about 3. How about this person? And for a 48-year-old in for pre-employment screening. Well, there's the P wave. And we can measure it. I mean, it starts about here. There's 1, 2, 3. So it's really 3. I mean, 1, 2. Oh, sorry. 1, 2, 3. So it's just maybe a hair shy of 3. But the key is, where's the PR segment? Remember, a PR interval has to have a P wave and a PR segment. There's no segment, so this is not. This is messed up. This is not a normal PR interval. In fact, you can see what's happened here. Remember, did Dr. Doe teach you the straight edge rule? When you have a QRS complex, here's the isoelectric line right here. QRS complex has to be built with straight lines. There's the Q, here's the R, and there's the S wave. And that's terrible, but they're all straight lines. That wasn't a very good Q wave. Straight lines. And you can see we don't have a straight line. In fact, we have a little hump right there. And then it goes up. So that's built with 2 lines. That's another way. And when we talk about QRS, the width of it, this is way too wide. So this is a patient with Wolff-Parkinson-White syndrome. All right, everything I just said. Okay, so shortened PR interval. What's the cause of a shortened PR interval? Well, we just did examples of a junctional ectopia. So a ectopic focus in the junctional region can certainly do it. A hole in the fibrous skeleton, we just saw Wolff-Parkinson-White syndrome. That patient, that definitely took away the PR interval. If you have no PR interval, you have a short PR, or I'm sorry, it took away a PR segment. So without a PR segment, you don't have a normal PR interval. So that can do it. A similar condition is Langerhans-Levin syndrome. These are pre-excitation syndromes. We will talk about those. But that can also do it. And maybe this slowdown portion, remember the slowdown portion of the AV node, that's what makes the PR segment. If that's damaged and the signal from the atria goes right through the ventricles without slowing down, you won't have a PR segment. So therefore your PR interval will be abnormal. 65-year-old man, some neck pain, dyspnea on exertion, not feeling good, diabetes, kind of a mess. Had myocardial infarction 3 years ago. Here's his EKG. What do you think? And that's not atrial fibrillation. Those of you who might be more advanced, that's just limb lead, just kind of artifact. Well, yeah, look at this P wave again. It's upside down. We do have a little tiny segment on that one, but really not much there. How's the, yeah, I heard somebody say bradycardia. You're right. So that's 300, 150, 175 Deacon Jones. 60, 50, 43, 37, and down in this area. So once you see it under 37, it's going to be in the 30s somewhere when we use the 1500 millimeter rule. So it's definitely a bradycardia. This is not a sinus rhythm. Who's running the show here? This is probably the AV node running the show, because the dots here, the same pattern goes on and on and on. So this is just a junctional escape rhythm that's going on here. Right. Everything I said, you can pause and read everything I just said. All right, and again, when the heart rate goes under 60 beats per minute, maybe normal actually. That's bradycardia though by definition. Some well-trained athletes may be down in the 30s. Not down in the 20s though. That's trouble. But yeah, so when is it a problem then? When does bradycardia become a problem? When the patient becomes symptomatic. When the heart is so slow, they start having dyspnea and on exertion. They start getting dizzy, things like that. What are the symptoms of bradycardia? Malaise, low energy, pre-syncope. That's that kind of dizziness, getting ready to pass out is pre-syncope. Maybe starting to get a little white looking and maybe even a little blue looking if it's slow enough. How about the causes of sinus bradycardia? Maybe you're just in fantastic shape and it's a normal bradycardia. But people with head trauma, intracranial pressure, obstructive jaundice is associated with it, myxedema. Beta blockers, grandma and grandpa again, if they forgot, they're supposed to take one beta blocker a day and they forgot and they took it at lunch and dinner, that can definitely cause a bradycardia. For more precise measurements, I think you know this already, you can count the number of little boxes, the 1500 box rule, little box rule. You can 1500 divided by the number of little boxes will give you a more accurate heart rate. Let's try it with that same patient. So it looks like kind of one box after the main hashtag here. So that'd be 5, 10, 15, 20, 25, 30, 35, 40, 45, 46, maybe 47, 46 and a half or so. What did I say? 46 and a half. So you do the math, 1500 divided by 46.5 little boxes, you got a heart rate of about 32 beats per minute. That's definitely a bradycardia there. Is this a sinus rhythm? This is not in sinus rhythm. Who's running the show here? Most likely the AV node is running the show. Even though we do have a little ledge here, it'd be unusual. The atria usually don't provide a sinus rhythm like this, because the atria can look like right is upright, left is downward. This could be a right pack premature atrial contraction. They don't usually pace the heart like this though. Here's a 72-year-old man who had a myocardial infarction 6 weeks ago. Has neck pain, back pain from the hospital. You run an EKG before you treat him. That's the pattern. It goes on and on and on. What in the world do we have here? Well, I don't see anything here, right? Where's the P wave? There's the QRS complex. That looks fine. What's going on with the T wave? Yeah, so what we have actually is an inverted P wave that is dug into the T wave. So this would occur if the ectopic foci is in the bundle of His. So it's still and if it goes on and on, it's an escape rhythm. Did it have dots? Yes, it does. Heart rate came out to be 35 beats per minute, and that's a junctional escape rhythm. But strangely, this one's coming from the bundle of His. How do we know it's coming from the bundle of His? Because the P wave is after the QRS complex. If it was coming from the distal part of the AV node, it would be here and hidden. Couldn't see it. If it's in front, it's the proximal part of the AV node. Got it? All right, that's enough of those. Let's go to PACs, premature atrial contractions. Oh my God, here we go with the AKs again. They're all over the place. Super common problem in healthy hearts. So there's definitely, probably every one of you guys has had one of these in your lifetime. They're really common. A few PACs are super common in normal hearts. 60% of adults will have at least a few of these during a 24-hour monitoring. You can stick a little EKG, portable EKG on your heart and watch it for 24 hours. Over half of you are going to have one, even at your age. And if you're older, 99% of people over the age of 50 had at least one in 24 hours. So they're incredibly normal. What are they? They're an ectopic foci that occurs in the atrial myocardia. And the ectopic foci is pacing the heart for at least one beat. And so you do have an arrhythmia if you have these things. They typically don't do rescue beats though. The AV node, the junctional region, is more for rescuing the heart. These are more mischievous. So they don't do. In fact, let me put a note to write that down since I have a pen right here. These are PACs. They're usually not rescue. I'll put a slide in there for that. Yeah. A very common cause of something called palpitations. Did I say that yet? If you become aware of your heart beating irregularly, you have palpitations. If you don't feel anything, you don't have palpitations. That's like a symptom, the patient's symptom. You can still have an irregular heart rate, but if you feel that irregular heart rate, you have palpitations. What do you do when you discover them? We talked about sending the patient to a cardiologist to let that get worked up. They'll do a 24-hour, there's an old 12 lead. I just had one of these done last year, and they don't, by Stanford, and they don't use these anymore. Here's, well, actually, no, because that was done by another cardiologist who was an idiot. I fired her. Don't get me started on that. But she did have kind of an old school. I wore one of these for 24 hours. They lost it, though. Then they did. They lost it. Then I went to Stanford, and they have this new technology. It's like a giant Band-Aid, and you can go in the shower with it, and you wear it for 2 weeks, and it records your heart rate for 2 weeks. It's not a 12 lead, but they can. I mean, it gives you the limb leads and enough to see what's going on. So you get it worked up by one of these if you have palpitations that you just discovered. Can they cause trouble? Sometimes. Now, many times, again, they're completely asymptomatic, but in some patients, they can be troubling, especially if you have pre-existing heart problems. They can spark tachycardias, is one of the problems with these things. And sometimes they're completely innocent, but the patient becomes aware of them and becomes very anxious, and the anxiety causes all sorts of trouble. What type of arrhythmia could they spark? Well, in people predisposed, they can spark atrial fibrillation, atrial flutter, and definitely the supraventricular tachycardias, AVRT and AVNRT. We'll talk about those when the time comes. They typically don't spark ventricular tachycardia or fibrillation, so that's good at least, because these will kill you. If the atria is going cuckoo, you don't even need your atria working. But you can't have you need your ventricles contracting synchronously. Some warning signs. So they can be, if you've never had them before and all of a sudden you're getting them like crazy for no reason, that could be a sign of coronary artery disease, ischemic heart disease, from your arteries getting clogged up. Myocardial infarction, it may be occurring. Hypokalemia, thyrotoxicosis, which is hyperthyroidism, valvular disease can all present as palpitations, so they can be a warning sign. I like this slide. I guarantee you this is going to be on the test, and I want you to know this word. Those of you who are actually listening to the videos, I'm giving you one. Dextromethorphan is the main ingredient in this wonderful medication here, Mucinex. That thing will dry you up if you've ever had a nasty cold, which we all have had, and you got mucus, you can't sleep at night. This stuff is miraculous. I can't take it because I have some arrhythmias, and my palpitations will go crazy if I take this stuff. It's also in NyQuil, so look for if you do have problems with PACs or PJCs or PVCs, can't take this. Some other things you can't take, or if you want to cause palpitations, you do these things. If you don't want to cause them, don't do these things. Stress, lack of sleep for sure. If I don't get enough sleep, my heart will get very irritable. Fever, thyroxine excess, tobacco, caffeine, chocolate, coffee. I don't drink coffee. Can't eat much chocolate. Alcohol, can't drink much alcohol. Because it'll definitely, it's not the day while you're drinking it, it's the day or the two after you're drinking it, it gets you. And then these decongestants, so you have to be very careful with that. What about treatment? The best option is to, why this comes up, I have no idea. Learn to ignore them and live with them is the best treatment. Eliminate the risk factors. Then I've tried this. This actually works really, really well. I don't have to use it very much, but it's great. Metoprolol is a beta blocker, but it's not for blood pressure, it's more for controlling the heart rhythm, and it does a pretty darn good job of it. Then if they have anxiety, you can give them some Valium, psychotherapy to help with that. If you have a high burden, I think Stanford uses a 30% burden. If 30% of your heartbeats are actually palpitations, or actually PVCs or PGCs or PVCs, they will go after it. They will map and try to figure out who the ectopic foci is, and then they'll try to burn it and destroy it. And it's kind of hit and miss, that procedure. It can be life-changing though. What about the EKG findings of someone with PVCs? So they can be a little tricky in a way, but not really. If you learn to watch these RR intervals, you'll pick them up, because there's not too many conditions that mess up these intervals. But this is one. Atrial fibrillation, interestingly, does as well. But look for these, because usually, like, this is the normal interval between the R waves, and I would expect that again and again and again. Then all of a sudden I see a short one. Usually the short one is the PAC or PVC or whatever it is. This happens to be a PAC, and that is not a normal beat, is it? What's the matter with it? It's inverted, right? There's a P wave, P wave, P wave. This one's upside down. And because there's a nice long PR segment here, this is not coming from the junctional region. And then we go by the rule, right is upright, and left is the opposite. So this is a PAC coming somewhere from the left atrium. And yeah, that's a run-of-the-mill pack. And then there's the concept of the compensatory pause. So look at how long the RR interval here. It's too long. The normal, let's count these. That's why I put this in here. Each one of these is actually 5 little boxes. These are just the big boxes. So 1, 2, 3, 4, 5, 6, 7, 8, 9. We'll call it 10. Then we have this, but then it should go back to 10, you would think, but it doesn't. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. See, it's too long. The beat after this will be back to 10, but the beat after a PAC will be too long. It takes a while for the SA node to set, and so there's an extra delay. That's called a compensatory pause, and that's classic of premature atrial contractions. Okay, the PR segment is typically normal or even longer than normal, because if the, do you have a picture? It's one's coming up. But if it happens, if the atria sparks an action potential, there's no Bachmann's bundle there to capture it. The wave spreads via slow spread, and therefore it can kind of drag out that PR segment or PR complex, make it longer because it's kind of slow moving. In some cases though, what if a PAC occurred right next door to the SA node? Then it would be really hard to tell. It would look like a sinus heartbeat. It would be hard to tell the difference on that. Okay, some more fun facts about EKG findings. They typically occurs right before a normally scheduled P wave, right? Because a normally scheduled P wave, there's a P wave, there's a P wave. The P wave should be about here, so it occurs before the next scheduled P wave, and that's why this RR interval is short here, if that makes sense. Let's see, rarely it could be before or within the T wave, but I'm not going to show you. Those are pretty rare examples to my understanding. And it's important to understand, even though there's a compensatory pause, the ectopic foci, or what happens after the ectopic foci, the ectopic foci will still give you a normal QRS complex in T wave. The only thing that's messed up in a pack is the P wave. because once the signal gets into the AV node and through the AV node, the ventricles don't know that things are messed up. So your QRS complex and your T wave will be normal. All right, 20-year-old athletic. Is this the same one? I don't know. Yeah, this is the same one we just kind of looked at. So there's the compensatory pause. There is a right is upright, that's down. So that's a pack coming from the left atria. There's a compensatory pause right there. We kind of talked about this already. But the one, notice that here's the mess up, right? The atria we're told to contract via a different master, not the SA node, but by an action potential. But once the signal gets through here, there's the slowdown portion of the AV node. We have a normal QRS complex and a normal T wave. This looks exactly the same as this. That's kind of the point of that. All right, P waves. What else do we need? Everything I said about right is upright. So if you see an upright waveform, P wave, that means that it came from the right atria. Right is upright. And if it's downward, it means it came from the left atria. We're talking about pack still. So right is upright. If it's inverted, that's going to be from the left atria. Let's look at another one. 44 enters you practice with neck pain, anxiety, funny movements in the chest. What do you think? Well, look at the RR intervals. Whoa, those are, you can see them, right? They're short there. So that usually means this is the culprit. So let's look at a normal one first. So there is a kind of a short PR segment normally in this person. But nevertheless, that is normal for this person. But here's the T wave, and then we got something really funky here with no PR interval here at all. And so that's just right is upright. That's a PAC coming from the right ventricles. The short PR segment tells me that this occurred really close to the AV node. That's the only reason this is so short. It can't be a PJC, right, because it's upright. But because there's basically no PR segment, the only thing that can do that is a pack that's really close to the AV node. Right, so here's trying to show you that this is a premature atrial complex or contraction or complex. It's occurred in the right atria, and it's really close to the AV node. So the camera is going to see a lot of this current heading right at it. So it tends to draw it upright. But because it's so darn close to the AV node, you're not going to have much of a PR segment. There's no time for it to monkey around going through everything here. 64-year-old comes to your office, a routine physical. What do you think? We actually saw something like this. Did we? Maybe we didn't. Well, look at the RR intervals. Whoa, short one, really short. That tells you this must be the problem. If we look, yep, let's look what the normal P wave looks like. Yep, it's upright, normal PR segment. And this is inverted, right? Now, the question is this coming from the junctional region? Because junctional region ectopic foci produce inverted P waves. But no, this one's got a nice little PR segment here. So this one is definitely coming from the left atria. Just a run-of-the-mill left atrial pack. And the compensatory pause is right here, which gives you more evidence. PJC doesn't do that. Only the PACs give you that compensatory pause. Alrighty. That's everything I said. You can read through there. And it's probably coming right here, and it's taking time to kind of creep over. One more. 33-year-old male comes in for a pre-employment physical. He's in excellent health. Is that true? Well, he might be in health, but he definitely has you're going to send them to the cardiologist to get it cleared for the job. Because look at the RR intervals, really short here. And if you look at it, we got an inverted P wave with 0 PR segment. So who could that be? If there's no PR segment, that's got to be an ectopic foci coming from the proximal AV node. And that's what it turned out to be, PJC in this patient. All right, so a lot to study. I don't think you know much of this, so take your time, go back through the video. See you later.